Good morning. Welcome to everyone. Thank you all for coming, whether you are joining us here in person in Rangos Auditorium or somewhere else virtually. We thank you all for taking the time to join us for the special grand rounds and special award presentation this morning. Today, we celebrate the memory of an exceptional physician and an aspirational leader who really laid the foundation of who we are as UPMC Children's Hospital of Pittsburgh, Dr. Eugene Wiener. Gene's career at Children's began in 1972 as an assistant surgical resident. Amongst his many contributions, Gene had a long-standing interest in the management of children with cancer. His involvement included serving on the Children's Oncology Group, the nation's largest clinical research organization devoted to pediatric cancer. Gene also received multiple research grants to investigate aspects of pediatric cancer treatment, and he published extensively on surgical oncology and venous access, with a count of over 85 journal articles. Gene played a key role in the development and design of Children's new location here in Lawrenceville. He played a key role in us being the first children's hospital to roll out an electronic medical record system with computerized physician order entry. I wished I'd had the opportunity to meet Gene, but his legacy with safety and quality is a big part of what brought me here and a big part of what is near and dear to all of us here at Children's. I'd like to introduce a special guest today, Jeff Wiener, who is Gene's son. Jeff, I invite you to come up and say a few words.
Good morning, everybody. I just wanted to, just say thanks again to Children's Hospital and everybody associated with keeping my father's memory and legacy alive and well. I also like to thank Karen Anderson for coming. It's my father's longtime assistant and right hand, I'm sure. And everybody else, again, who's here. And congratulations to Dr. Moreau. And just, again, thank you, everybody, and hope everybody enjoys the lecture as well. Thank you.
Thank you, Jeff. Thank you to everyone who submitted nominations for this year's Eugene S. Wiener, MD Award for Excellence. We are grateful to have so many nominations. It is my pleasure to recognize this morning Dr. Victor Morell with the honor of receiving this year's award. In fact, it was Dr. Wiener who was the one who recruited Dr. Morell here a little over 20 years ago, is in 2004. Just a few words about Dr. Morell. Dr. Morell did his medical school in Puerto Rico, surgical residency training at Robert Packer Hospital in Pennsylvania, and 2 pediatric cardiothoracic surgery fellowships at Boston Children's, as well as at Great Ormond Hospital for Sick Children in London. Just a couple notable accomplishments about Dr. Morell. In his time here, Dr. Morell has grown our cardiac surgery department and transformed us into a world-class heart institute. He's retained and recruited absolutely top talent. He's grown volumes exponentially over the years, resulting in patients coming here to Pittsburgh from all over the world. In addition to the exceptional pediatric program that he leads, Dr. Morell is also one of the most highly respected physician leaders in all of UPMC. You may not know that he also chairs the UPMC and University of Pittsburgh School of Medicine Department of Cardiothoracic Surgery. He's recognized and respected for his clinical brilliance and surgical skills, his exceptional team building and relationship skills, and above all, his passion for excellence. He truly embodies the facets of true professionalism. For those of you who know him, for those of you who haven't had a chance to interact with him, he has a great sense of humor, he has great skills in people skills, and he's very grounded in humility. As an educator, he's fierce and passionate about his job, and he expects that same diligence from those he trains and those that he oversees. He has a gift. It's not just dexterity in the operating room, but the speed with which he accomplishes his goals. Clearly, our Heart Institute and our success is representative of that. He emulates authority, but hasn't lost the common touch. And again, those of you who've interacted with him know exactly what I'm talking about. He's also taught us to be comfortable that sometimes it's okay to say, I don't know, or I just don't know if this can be done. It's not a sign of weakness, but rather a true sign of strength. Before I call up Dr. Morell, I'm going to call up our hospital president, Diane Hupp, to say just a few words, and then we'll award Dr. Morell the award.
Thank you, Dr. Buchert, and I'll be just a moment up here, but I'd be remiss if I didn't say a word about our dear colleague, Dr. Victor Morell. I have had the privilege of working with Victor for the 20 years that he's been here. And 20 years ago, I do recall the day very vividly when our very own Dr. Eugene Wiener had called me. I was working in the OR and said, Diane, I have a very important recruit coming from Florida today. So please put on your best and make sure everyone in the OR is putting on their best for Dr. Morell. And I remember Dr. Gene Wiener bringing you up to the operating room. And we must have put on our best because we did end up getting you. But I want to thank Victor for so many things that were already said by Dr. Buchert. But I'd also like to remind people when Victor came here 20 years ago, we had a great heart center. And I accentuate the center. When Victor came, one of the things was his vision that he wanted a heart institute. And he was very clear to us as leaders on what a heart institute means. Now, I'm not sure if he dreamed of the 50,000 square foot building we're putting up, but I do think he dreamed and had visions of expanding the people and the multiple disciplines that work together side by side every day in our Heart Institute. So Victor, I could say a lot more up here today. I just asked for a moment or two. My sincere congratulations on a personal note. Congratulations from the entire organization, all the children and the families you serve. There's barely an event I go to, and when heart is brought up, Victor Morell is brought up. Victor, you are respected more than you know in terms of what you do, who you are, what you believe in, and the passion you exude day after day, hour after hour. Thank you. Congratulations. And our Dr. Wiener is smiling and would be ever so proud of his recruit. Congratulations.
Thanks so much. Thanks so much. I feel like this is a pre-retirement speech or something. I hope not. First of all, it's been very easy to excel in this environment. I mean, the support we get from the administration, from all of you. I mean, this is a team effort. This is by no means, you know, I would say it's just, you know, I participated a little bit on it, but obviously everybody else has made it happen. You know, it takes a whole team. So I'll take some of those accolades, but measured for sure. It was interesting when Gene was instrumental. You know, my endowed chair is the Gene Wiener chair, and it's funny because he was not a heart surgeon, but you know, I think he did have a paper published on pericarditis. I researched that. So it wasn't that far-fetched. But Gene was really a friend. The day I came for that visit, Diana, you don't remember this, but it was 75 degrees. I flew from Tampa, Florida. That night was 20 degrees and snowing. Okay, and Gene got me to come. Okay, so that says a lot about Gene. He taught me a lot. He taught me he was a humble guy. He was passionate, extremely passionate, and he had a love for children that was incredible. So he left a legacy, and we all feel it. For those of us who really, you know, had a chance to know him, we miss him. He was a great guy, and he left, you know, a significant legacy on all of us, and I'm happy to be here, and thanks so much, and we got work to do. Thanks.
Congratulations again, Victor, and thank you to everyone for joining us today for this special lecture. I'm going to call up Dr. Scott Maurer to introduce our grand round speaker today.
Good morning, everybody. Thanks for being here on this special day. I'd like to introduce Dr. Richard Antonelli, who is a national leader in the care delivery and care coordination for children with medical complexity and youth with special health care needs. He has served in senior roles with the HRSA and Maternal Child Health Bureau, funded initiatives including National Center for Care Coordination and Technical Assistance and the National Care Coordination Academy, and he's contributed to the development of national standards for children and youth with special health care needs. Dr. Antonelli has advised many major policymakers and payers like CMS on performance measures and policies to improve the transition from pediatric to adult care. And he currently co-leads an HRSA-funded coordinating center for enhancing systems of care for children with medical complexity and serves as an advisor to the school-based healthcare coordination initiative. As someone who's very invested in the care of children with medical complexity, it's very much my honor to introduce him as our speaker today. Thank you so much.
Well, I am honored to have been invited to deliver this talk. Congratulations to you, including your time in Boston and coming to Pittsburgh. But the spirit in this community is palpably positive. The history of Pittsburgh is wonderful, and I'm just thrilled to be here and to see administrative leaders and all these disciplines. And I was glad when you described the Institute as a bunch of different disciplines working together. So that's going to be kind of the soul of my presentation today. I have no financial relationships and no other disclosures. Land acknowledgement: the land from which I work is located on traditional, contemporary, and unceded territories of several indigenous nations in Massachusetts, including the Massachusetts, the Mohican, the Nauset, the Nipmuc, the Pennacook, the Potomac, the Wabanaki, and the Wampanoag. These lands were taken from the indigenous people, creating a legacy of trauma that persists to this day. And I feel like I know Dr. Wiener. I'm a beneficiary because a lot of the work that I do is in the safety space. And I'm going to share some of that with you today. I had the privilege of being influenced a bit by one of Dr. Wiener's colleagues, Lucian Leap at Harvard. And it was pretty startling for me as a physician in training to, safety, we don't really have to talk about that because everything we do is always perfect, until you measure it and then realize, it's not always perfect. And then when you ask the patients and the families and give them the right context, you learn all kinds of opportunities to improve. It's not a blame game. You embrace the opportunity to improve. So there are two goals in my career. This is a place where I can intersect with my dear friend, Dr. Amy Hutro, who said to me, her two goals in her career, one, to publish something in the New England Journal of Medicine, and two, to one day be on Sesame Street. She actually said that. For me, this man represents so much. This is the epicenter of love and inclusion, of multiculturalism and inspiration. So I am honored to be in this man's backyard. These are the learning objectives for today, and I apologize if I'm going too fast, but I want to try to leave time toward the end. So understand the elements of a care integration framework. I want to prove to you it is age non-specific. It is not specific to medicine or surgery. It includes social well-being. Attendees will know how to access, adapt, and implement tools to actually measure the value. That V word is going to come up quite a bit today, of care coordination. Understand the link between high-performing care and safe care delivery, and identify opportunities to inform health policy, aiming to advance value, and health and social justice. I'm going to start with a true case. I was precepting in our primary care clinic a few years ago. 4-year-old boy whose mom had immigrated from Guatemala was and came to Boston Children's and transferred his primary care to our site after quite a few emergency department visits, primarily for reactive airways or asthma, initially diagnosed at 9 months of age. He kept being identified even by emergency room docs as, there's something about this child's development. We need to flag this and make referrals. In the year prior to transitioning his care to us at Boston Children's, he was in the emergency department 3 times for asthma. Had never had an assessment for his attention or his developmental status. The painful irony here is that all of the care quality measures were met. Everybody that saw him, primary care, made an assessment and made a referral for developmental and behavioral assessment. Even the emergency room docs would say asthma, first diagnosis, second diagnosis, behavioral concerns. Referrals were made. Unfortunately, not one person in this entire ecosystem ever said, did that ever happen? So for me, this captures what's missing in healthcare generally. I won't take the time now to do a poll, but I'm sure everybody in this room has either personally, directly, or indirectly through friends and family experienced this notion of who was supposed to make that happen? We have a way of measuring that. So a research colleague of mine who has since moved to Sweden, Kristen Lind is her name, and I were doing a care coordination measurement project some years ago. And I said, your son, Gabe, is really complicated. What does life look like for you? And she proceeded to demonstrate all of the aspects of Gabe's village. In the left lower quadrant, you can see primary care, subspecialty care, and in the left upper, all educational resources. In the right upper, you can see things like the LEN program and family advocacy training. In fact, that is really important. Families and caregivers who have kids with medical complexity or significant chronic conditions need training to navigate a system. Healthcare is not intrinsically or organically designed to be self-service. We hope that it is, but systems often expect that it's going to happen, and it doesn't. And that opens so many opportunities for harm and for low value care. So think of Miguel. Miguel's initial diagnosis of autism was at 4.5 years of age. Years of age in Boston. You can't throw a scalpel without hitting at least 10 physicians in Boston. And yet, in spite of all of those touches, he had access to care. He was not a lost to follow-up child. He had access to care, but the system didn't recognize it's not enough to make a referral. There has to be a way of stewarding those resources in an accessible way. So this is the care map. You may have heard about it. It has been written into so many different policy pieces across the US and around the world. And in fact, at the end of the year, we'll be having a free app in the App Store so that families can organize their care using the care map. So when I got to Boston, I wanted to find out who are these complicated kids. And so I did an analysis, and this data goes back to 2016, but it's still exquisitely relevant today. At the top of this pyramid, which represents all children, it's 1.5% of the pediatric population in the United States. These are children with neurodevelopmental disabilities, autism, and comorbid conditions, significant behavioral and psychiatric disorders, hem-onc disorders, including sickle cell, hemophilia, technology-dependent kids, cystic fibrosis, social risk factors, and so-called adverse childhood experiences. The 1.5% of the children at the top of this pyramid are responsible for 40% of all of the money that gets spent in Medicaid in the United States. In the middle of the pyramid, it's about 20 to 25% of the pediatric population. These are kids that have behavioral disorders, but not polymorbid, but sort of monomorbid, if you will. Just, air quotes, ADHD, just depression, just anxiety, just PTSD, asthma, obesity, diabetes. So if you look at the 1.5% at the top and the 25% in the middle, you're looking at 90% of all of the dollars that Medicaid spends on child health. And by the way, it translates into commercial payers as well. So this is not just public payers. And 75% of children don't have those conditions. Now, remember, that was 2016. Jump ahead now, and any child that's living in the community is exposed to significant issues of feeling marginalized, feeling unsafe. This is where channeling my inner Fred Rogers, lack of inclusion, marginalization, et cetera, et cetera. So I would actually argue that at this point in time, children across the country, 100% of them have some risk factors for social, behavioral, developmental, if not medical conditions as well. So what can we do about that? Can we find common ground in our search for value? I'm glad the president of the organization is here today. We're going to be talking a lot about value, but value for whom, right? For the payer, the value is we're not wasting any money. The value for the delivery system is you're able to continue to keep the lights on and recruit staff and deliver the services that you need to do. But the value for the family is to keep my relationships in the community going, to keep my job, to have my child get to high school and college graduation and become gainfully employed. Those are not diametrically opposed, but we need to figure out where's the common ground in the middle. So I want to keep stressing the term value because it is written all over federal guidance for what healthcare needs to be. And the good news is I'm not going to be aiming today at blue sky. We're going to bring this down to, so what can you do in clinic next Tuesday? What can you do in the boardroom as you're configuring the teams that you have and the type of care they need to deliver? A colleague of mine who has been the Medicaid medical director in Ohio for many years, Mary Applegate, and her colleagues came up with this graphic. It looks at some of these three levels, the macro system, the meso system, and the micro system. And you'll notice each of those little boxes represents a quality measure, or it represents a policy, or it represents a payment methodology. The higher you go at the macro system, you have fewer. The lower you go at the microsystem. So in the cystic fibrosis clinic, in the transplant clinic, in your primary care clinic, there are more things to do. And where systems become important to integrate is to align these measures at the systemic level, at the macro system level, with healthcare policy, with sustainable financing mechanisms, and then recognizing what the community factors are. What are the strengths and what are the needs of the communities that you serve? I want to call out an issue that is a pain point for me is the notion of satisfaction, measuring patient satisfaction. It sounds reasonable. However, it's very subjective. And in fact, the experience generally with traditionally underserved, under-resourced, and/or marginalized communities is they're satisfied because you pay attention. Doesn't mean they got the best care. And so I only use the term satisfaction to say, please don't use satisfaction. I call it experience. What is your experience accessing us? Is your child in a wheelchair able to get into our clinic? Do people understand you when you speak with them and vice versa? And we're going to get more deeply into how do we measure experience. And then the definition of harm. much of the work that much of the work in the literature around harm in healthcare comes from hospital systems. And with all due respect to Dr. Wiener and to the award recipient here, thankfully, they identified reduction of harm mechanisms in hospitals and in surgical spaces. Think about Miguel. I would argue that Miguel experienced harm. In fact, his mom was satisfied. Why? We took care of her son, but we were 4 years late in making his diagnosis of autism. And for those of you that may not appreciate autism, the sooner you intervene, the better the outcomes. Okay? So defining harm more broadly, it's not just wrong site surgery. It's also making a referral, presuming that the family is going to explain to the subspecialist what she or he needs to do. It's those gaps in care that we're going to talk about. Respect for the value of the time of the patients and families and the caregivers, and the delivery system, providers, their time, their sense of purpose, joy in the work. And it includes all team members. And once again, I'm thrilled that you talked about the Institute as having a multidisciplinary approach. I'm here to say that we have to move from the traditional hierarchical medical model that is deficit-based into a team-based model that focuses on things that are important to patients and families. Not only are the lions at the gate, they've come through the gate. So on the other side of the Commonwealth of Pennsylvania, Hahnemann Hospital was purchased by a venture capitalist, and basically all the assets were extracted and it shut down. Similar story to St. Christopher's. My mentee of many years, Dr. Renee Turchi, who is the pediatrician in chief over there, St. Chris was experiencing pretty much everything that Hahnemann did in terms of the venture capitalists coming in, but was able to make a pivot. I don't know if that's applause or if there's somebody upstairs and maybe they're hanging your painting upstairs. But this is critically important, and it is not unique here in Massachusetts. The investment firm that bought Chrysler and Mercedes-Benz, hint, hint, how much do you think they knew about healthcare? Also bought all of our so-called safety net hospitals 20 years ago. After they pulled $800 million out of the system and essentially mortgaged everything so that they could extract the dollars, the system fell apart. So, and I'm not going to bash venture capitalists. I said this to our colleagues last night. They're doing what they're supposed to do, extract profit wherever you can see it. However, healthcare systems have to figure out, and policy folks have to figure out a way to prevent them from becoming targets for mergers and acquisitions and takeovers. To really bring this down to the grassroots, the transformation, and I'm going to use that in a negative way, of primary care from common good to a free market commodity. Think about the evolution, the increased number of pediatric primary care practice and adult primary care practices that are now so-called boutiques. Now, again, we're not going to disparage, it would be inappropriate to disparage primary care providers. I am a PCP. This is how they keep the lights on. And we're seeing a shift in this country toward investment grade ownership of practices, which begins losing sight of what's really important to communities. So I want to talk a little bit about this. I'm still in the phase of this discussion, by the way, about what's happening in the ecosystem. I will not read all of these things to you. I just want to share it with you so that you know that my framework of integration and advancing policy, equity, safety, and value can actually occur even with these existential threats to healthcare. But this is HR 1. And you can see year by year by year what the impact is going to be on children, youth, families, and adults. Medicaid work requirements, limited windows for maintaining benefits so that children and beneficiaries will actually fall out of eligibility. SNAP, food support. These are all existential threats. There is a way through. 10 to 16 million Americans living with intellectual developmental disabilities. People with autism die at a rate 10 times higher than the general population. They die 2 years younger. They're 3 times more likely, 3 times higher with intellectual disability, and 6 to 10 times higher suicide risk because of autism. So these impacts on outcomes of having disabilities transcend age, pediatrics and adults as well. And then, of course, there's the intersectionality. So racial disparities. African-American children with IDD are often diagnosed years after the onset. Think about Miguel. Not till he was going essentially to kindergarten was he diagnosed with autism. He missed 3.5, maybe 4 years of preparatory intervention. Autistic people who are Black or Hispanic are twice as likely to report their or poor mental and physical health. And Black and Hispanic autistic people experience higher rates of diabetes and other chronic conditions. My dear friend and colleague, Lisa Iazzoni, did this study published in Health Affairs. Physicians, we're part of the problem. Lisa and her team looked at 700 plus practicing US physicians in family medicine, internal medicine, rheumatology, neurology. You could see that 82% reported that people with significant disability have worse quality of life compared to non-disabled people. 40% of physicians. Sounds like a big number, right? But it's only 40% of these physicians felt very confident about their ability to provide the same quality of care. This is what physicians do for a living, right? This is what physicians do for a living. Only 40% of physicians felt very confident to take care of adults with disabilities. 56% strongly agreed that they welcome patients with disability in their practice, but 18% agreed that the health system often treats these patients unfairly. This is work done by Stephanie Ames, and I see Amy is on this as well. It's sort of the pediatric view of looking at the perception of disability-based discrimination in healthcare for children with medical complexity. And it also tells a story that has implications for training, a story that has implications for interprofessional education and multidisciplinary performance. This notion of an institute, I think, is wonderful. And thankfully, you're bringing multiple disciplines into that institute. But think about this. If the medical establishment has issues with feeling confident to provide care to children with disabilities, there are significant barriers for these children and family to actually have a shot at equity. And that is what opens the door to some of the opportunities we're going to talk about today. Renee's over at St. Chris's, and I and our team looked at the National Survey for Children's Health and basically came to the following conclusions. Unmet needs in terms of adequate access or knowledge leading to insufficient provision of care coordination for families who had the greatest needs. So the more families had social drivers of health that limited their access, the less likely they were to be able to receive care coordination. It's a negative double whammy. So measure what matters. These are the domains of integrated care. This slide was intentional. This framework was intentionally designed to align with the World Health Organization framework on integrated care. The tools that I'm going to share with you in the next few minutes are literally in use around the world. and across the US. So one domain is care coordination. We'll define that in a moment, but we have ways of teaching how to do care coordination. We have ways to measure its performance, and we have ways to measure the outcomes of care coordination. And that is how you sustain funding to keep it going. There is the experience of care received, both the patients and families, caregivers, but also the providers. And we have to look at utilization and financial arrangements. This is a slide I'm going to make up some time on because I want to be very mindful of the time here. But I just want to give you a brief overview of both local, national, and global initiatives in terms of implementing and measuring care coordination. The theme on the left side is we can do this in primary care settings. We can do this in surgical subspecialty settings. We can do this in complex care services. We can do this in communities with community organizations that aren't even medical per se. And I'm going to show you an obesity model in a little bit that leverage this, and multiple relations around the world. Integrated care is the patient, family, caregiver reported experience of a seamless provision of services across the entire care continuum. It results from coordinating the efforts of all the providers on the team, irrespective of their institutional affiliations, departmental affiliations, or organizational boundaries. It's a sense that the families think about Gabe's care map. Gabe's mom was able to say how each of those elements around those four sectors either work together or not. Care coordination are the activities in the space between visits, between providers, between hospital stays that co-create with the patient, family, and caregiver and implement a shared plan of care. We're revising this 2014 statement now for the American Academy of Pediatrics. There will be strong focus. In fact, many of the elements what I'm sharing with you today about value are going to be in there. So here's that instrument that I was talking about with you. These are the 5 domains that map to the World Health Organization integrated care framework. Access to care, which means access to information too, not just when can you get an appointment. Communication between the patient and the family and the care team, and the impact on the family, care goal creation and planning, and team functioning and quality. These 5 domains, we have a validated instrument that allows families to report their experience of care. And I'll give you an interesting tidbit that came up at dinner last night. I'm from an academic medical center. This is an august academic medical center. Some of the most fragmented care that is delivered to children with medical complexity in the United States happens in academic medical centers where there are multidisciplinary teams. And I can see several heads going up and down because my hunch is you know what I'm talking about. And again, this is not being disparaging. Here's the reality. Physical co-location. So having 3 or 4 specialties in the same space for the morning so that families have a sense of, I can see ortho at 8 and I can see GI at 9 and I can see cardiology at 10. This is really convenient. When we administer this experience survey to these families, they often say, it was great seeing the 3 doctors, but I don't know who's in charge of my kids' care. I don't know who or how they're going to communicate to my PCP. Is that on my shoulders? And what about the school nurse? Who's going to communicate with the school-based team? And then don't even get me started about the soccer coach because my kid wants to play soccer, et cetera. So this is a wake-up call for all of us, right? We can be integrated because we have a multidisciplinary co-location. Or we can take a step back and say, but if it's integration from the perspective of the family, there's a lot of upside opportunity there. Care coordination measurement tool. we developed an instrument, and yes, I know it's 2008, but this was a bit of a pivotal moment in my career. First generation of capitation payment. For $6 a month per kid, I got to take care of kids on home ventilators. You heard that right, $6 a month per kid to take care of kids on home vents, which means that by 3 a.m. on January 1st, I blew through that entire year's budget. And then I was told by my leadership, well, Richard, just make it up in volume. True story. True story. So we scrambled. And in fact, the genesis story for the care coordination measurement tool, which I'm going to talk to you about now, was I needed to do something to save all of my care coordination staff from getting laid off. The non-billable folks, the nurses, the secretaries, right? The docs we can bill, but I shouldn't be calling agencies, setting up appointments for people. Not that that's below me, but if I do that, then that means that I'm not seeing patients. And so this work was the first manuscript in the pediatric literature that specifically raised and centered the role of non-billable, in particular nurses and social workers. We looked at 3,800 care coordination encounters across the nation and found that 62% of those encounters prevented an unnecessary visit. Example, this is an RN in a non-billable encounter walking a parent through the asthma action plan, which obviated the need to bring the kid into the ED or into the office. And in a fee-for-service paradigm, this will generate a sweat. Fee-for-service, for those of you that may not know what that means, you do something, you get paid. You do something, you get paid. And so therefore, you can think about the conundrum there. I got great news. We didn't need to send kids to the emergency department 26% of the time. Rich, you realize how much revenue we lost because of that? So talk about malaligned incentives. And this profoundly impacts communities that don't have the necessary resources for robust primary care coordination. We extended this into our pediatric GI clinic at Boston Children's Hospital. Similar findings. Non-billable care coordination avoided unnecessary emergency department visits, avoided unnecessary visits to urgent care, and even avoided unnecessary clinic visits to the GI clinic themselves. But I'll call your attention to the bottom of the left, and this is where the safety piece really comes in. Each of these encounters generally was triggered by the family calling into the clinic. They had a question. And often that question was, when was my kid supposed to come back again? But the nurses uncovered that 7% of all of those hundreds and hundreds of encounters, non-billable encounters, uncovered a discrepancy, a misunderstood care plan, an incorrect dose. And so we backed into the safety aspects of care coordination, but I'm really glad that we did. So I would say to you, even if you don't care what care coordination is, and even if you don't care what a care plan is, you owe it to the patients and families to do everything you can to minimize harm, which means you need to do care coordination. And then, by the way, there's an upside of care coordination because you can actually improve things. But there's a profound element of harm reduction in doing care coordination. And then I'll jump over this quickly, but we actually applied this to our spina bifida clinic at Boston Children's, and the nurses and the urology team had similar findings, annualized savings of $280,000 in prevented ED visits alone. 20 years later, I just let that hang there a minute. 20 years later, our adult colleagues caught up with us. And this is a study out of Harvard in the Annals of Internal Medicine, and they looked, what we looked at 20 years earlier, they decided, maybe there's safety opportunities in the ambulatory space, okay? And in fact, outpatient harm was relatively common and often had serious consequences. Transitions of care that were underinformed or misinformed or uninformed, which happened all the time. I was thrilled to see this because, yes, you might get some gargantuan errors on the inpatient side, and this is not UPMC, this is a global statement. But there are even more that are occurring on the ambulatory side, right? And so care coordination is commensurate with promoting a safe experience. Lest you think that this is a talk, that care coordination is just for kids. It isn't. So I'm putting this slide in here specifically out of deference to the number of times that I speak with policy, health policy at the state and federal and territorial level. Care coordination is for everybody. We used our care coordination tool that I just showed you with a very diverse population in Hawaii, with adults who screened positive for depression. We captured the number of non-billable encounters to get the patient engaged, to make sure there was a care plan in place. I'll emphasize non-billable encounters. And not only did we capture what the activities were, but we showed that it led to improvement in the outcomes of depression. Makes sense, right? Because the care plan is, here's how, now that we've diagnosed the depression, here's how we can treat it. And if you send the family out into the ether and they're supposed to figure that themselves, think about Miguel. But in fact, if care coordination is intrinsic to the system, could you get the medications? Are you ready to talk with our behavioral counselor next week? We have an appointment for you, et cetera, et cetera. So the reason the New England Journal liked this so much is because it's one of the first robust studies that showed care coordination has an impact on outcomes. That's how we can talk about baking in the financing pieces of care coordination. My colleagues at UIC up in Chicago have the CHECK program. It is a mini army of care coordinators. I did a visiting professorship there just a year ago, and it was absolutely wonderful. Leveraging community health workers, they put into place an integrated preventive behavioral health model. The outcomes, they stopped short of having the statistical rigor to say that it was anything more than an association, but it kind of passes the sniff test, right? Care coordination reduced unnecessary ED use. I've already shown you some mechanisms for that. It reduced school absenteeism, and it actually improved scores on the pediatric symptom checklist. So the UIC team is deploying these tools. I want to show you what a community would look like, a community model would look like. We built one with funding from the New Balance Foundation in the Boston area for diagnosing and managing overweight and obesity. This just came out in June of this year. And actually, this study happened right in the middle of that little thing called COVID-19. So we took 2 weeks, completely revamped the model and continued. And you can see what happened to the BMI of these children enrolled in this model. And I want to stress, this was not a model that said, PCPs, we know you're busy, but could you just think about obesity a little bit? Actually, no. We brought a team. We brought a team so that the PCP only had to do what they're supposed to do, which is identify these kids. I'm passionate about transitioning youth from pediatrics to adult care, especially those that have significant conditions. I had the privilege of offering expert testimony to the Medicaid and CHIP Payment and Access Commission earlier this year. The recommendations have now been published. For those of you in the audience that are passionate about transition and/or how the sausage gets made in policy, I recommend that you take a look at this MACPAC report. It is profoundly important, including allowing payment for pediatric subspecialists to support their adult counterparts as those adults get into those practices with conditions that the adults had never heard of. This is our hybrid integrated care model. In my clinical time, have 20, 30, 40-year-old people with conditions who are unable to transition to Mass General Hospital or the Brigham and Women's Hospital because of their complexity. In this clinic, we define a multidisciplinary plan of care, and before we give them a phone number of some unsuspecting adult PCP, we actually wrap that patient in a care team that includes nursing case management. And that is how we are able to get people across that threshold. So I want to bring us back now here. So coming back to this locus of financial accountability, and what a privilege for me, not only to be speaking to frontline clinicians and trainees, thank you, but we have the administrative leads here. This is important. Be mindful that the locus of financial accountability needs to be large, especially in a risk-based arrangement, which is what's likely coming out of the federal government in years to come, value-based arrangement. But at the local level, we want to know what are the measures that we're tracking to assure equal access, to assure that people leave and understand who's in charge of their child's care team. So be thinking about locus of financial accountability is not necessary, in fact, often is not the locus of performance measurement. Care coordination mandate for kids in Medicaid. I'm going to wrap up now. These are the core set measures. They are mandatory reporting. All of my tools and processes and training and curriculum are freely available in the public domain. And I think with that, I will just close by saying, find the common ground, persist with compelling civil global advocacy, build the capacity of families and a workforce, implement measures of integration, care coordination, and value, work across disciplines, leverage adult priorities when advocating for pediatrics, integrated behavioral health, social determinants, equity, and social justice. So with that, I'm honored to have been here for this moment. To the Wiener family, your dad's legacy clearly is alive, and congratulations to you. Thank you.